Data with the transoral robotic surgery techniques in head and neck cancer. The data that I'm presenting is really more focused on the HPV positive setting. So transoral robotic surgery permits the resection of pharynx tumors through the open mouth without the morbidity of jaw splitting and lip splitting. Surgery was approved in 2009 for T1 and T2 tumors. Post-op therapy can then be given based on pathological staging, for example, extracapsular extension. We were a little confused in our group when they started doing basically biopsies of a T1 tonsil cancer with the robot, neck dissection, and then the recommendation was to do radiation alone because it was an early stage. So the positive margins is a little bit more of a question, but extranodal extension certainly would require the chemotherapy and radiation post-op based on the information we have now. So rationale for dose de-intensification, and we heard a lot about this from previous speakers, that HPV is a better prognosis. They're typically younger patients who have longer years to survive the late effects of chemotherapy and radiation. And we know that dysphagia, aspiration, strictures, and feeding tube dependence increase based on doses to the pharyngeal constrictors. There are some trials investigating TORS in oropharynx cancer. ECOG 3311 is actively recruiting. We are opening it now. We got a late start, which is a long story, but we're opening it now. And my understanding is it's a little bit slow to accrue, but they're planning to stop accrual in the fall of next year. It's for stage 3 and stage 4A P16 positive cases. For the patients who are T1 to 2 with N0 to 1, those patients will be observed. If there's close margin, limited ECE, which is less than a millimeter, 2 to 4 lymph nodes, lymphovascular invasion, or perineural invasion, then they get randomized to 2 different doses of post-op radiation. And if there's a positive margin, gross extracapsular extension, or 5 or more lymph nodes involved, then those patients receive a more aggressive post-op therapy of 66 gray with weekly cisplatin. Washington University has their own phase 3 trial they're running. Also with the P16 positive tumors, these patients are enrolled with clear margins, but they have extracapsular extension. And the randomization is to really determine, it's a lower dose of radiation, but to determine if you can eliminate the weekly cisplatin. And part of the goal of this trial is to try to eliminate radiation altogether if you have an early stage tumor treated with a transoral robotic surgery that doesn't need any post-op radiation. There are other trials that are ongoing, and I apologize if I've missed something. The ADEPT trial is a T1 to 4 and 1 to 3 with extracapsular extension, again, P16 positive. And the randomization post-TORS is with IMRT or IMRT with cisplatin. Their primary endpoint is the 2-year disease-free survival and local regional control. The ORATOR trial randomizes between IMRT and TORS for a more earlier stage population with the 1-year quality of life as its primary endpoint. And then there's a PATHOS trial which gives patients therapy like the ECOG trial based on their post-operative risk. That also has a quality of life endpoint as its primary endpoint, but they're following for survival and recurrence. So it's a little bit less controversial for the TORS for the early stage tumors. Why should we expand it to more locally advanced cases that can, hopefully be treated in the future based on some clinical trials with less radiation, less chemotherapy? Why should we move this into the treatment mix? Well, the local failure, even with the best patients at the 8-year follow-up for the RTOG 0129 trial, was 13%. And these were in those good risk patients that didn't have a high T stage. Well, they didn't have a T4 and they had no N2B or N3, were never smokers. The other rationale often provided is, if you have a TORS and you have a neck dissection, you may be able to avoid chemotherapy if there's no extracapsular extension. And there's been data published, I don't have it here, that shows both for HPV positive and HPV negative patients looking at CT scans to guess whether there's extracapsular extension is pretty lousy. So a recent review was published of the literature that's out there regarding TORS, and it's a little bit dismal. This review is limited to cases involving oral pharynx. So basically, there have been no randomized trials published between 2001 and 2015. The median sample sizes are generally small. IMRT median sample size 71 versus the TORS, which is 30. And as expected from these trials, HPV, age, smoking, stage, all influence survival. And in the trials, the average hospitalization if a patient undergoes a TORS is 3.6 to 3.8 days. The risk of feeding tube dependence is influenced by age, smoking, advanced nodal disease, and whether or not they received chemotherapy along with adjuvant radiation, with a mean TORS feeding tube rate of a little less than 4%. So the trials that were looked at in this review, here are the demographics. And as one kind of fitting the demographics of the cancer, 80% of the patients are male. In the patients treated with TORS reported more patients had an earlier stage than the patients who received IMRT. Less patients had positive lymph nodes in the TORS group at diagnosis compared with the IMRT. And again, the stage was different too, with higher stages in the IMRT groups that were reported out. So the quality of life data that we have has been measured by a hodgepodge of quality of life assessments. But some of the things that we can glean from the data that's out there, there's a survey, head and neck 35 survey that was used in patients comparing TORS plus post-op IMRT and IMRT alone. And that quality of life analysis showed that there's increased dry mouth with primary IMRT arm. There's another quality of life that showed that after the TORS, the speech decline had persisted at 12 months, but the eating and the diet had resolved back to normal. Another quality of life that compared about 20 patients who had TORS and 20 patients who had chemo and radiation. And in this study, the TORS, it's a little more relevant, the TORS group all received post-op adjuvant radiation or radiation and chemotherapy. And interesting in that study group, by 6 and 12 months, the winner was the TORS group. University of Washington has their own quality of life scale. And when they looked at initial surgical resection versus definitive chemo and radiation, the swelling was actually better for the surgical arm at 1 year, with 74% of patients who had TORS reporting that their swelling was as good as ever, compared with 32% in the chemo radiation arm. And the next two slides are just our tables with feeding tube rates. The one with the highest rate is actually Dr. Al-Qadari, who's our junior oral oncology surgeon at Rush. But this is high because there were salvage surgery patients included in that, and a lot of patients who received chemo and radiation. But you can see that in these TORS series, there are a lot of zeros for a lot of zero feeding tube dependence. For IMRT in the review, you don't see any zeros. The rate is quite variable, but a little bit more feeding tube dependence. So what do we know about cost? That was a big subject, especially earlier in this conference. So TORS versus primary IMRT for early stage cancer is cost effective, with a cost savings of a little over $1,300, 0.25 quality adjusted life years. However, the more times you have to add post-op radiation, it becomes less cost effective. So the next group of slides are focusing on a manuscript we put together looking at cost effectiveness of moving TORS to the more locally advanced setting. So it was a Markov model based analyzing primary chemo radiation versus TORS for N2 positive, HPV positive oral pharynx cancer. So we had hypothetical patients that transitioned through different states. I'm going to just go through this for all the people like me who have a slightly deficient health sciences, public health statistical background. So basically in this model, you were in a given state at a given time period. So for the primary chemoradiation therapy arm, treatment lasts 7 weeks. And then there's a 3-month period of recuperation. After the PET CT, then patients with PET CT positive disease had a modified radical neck dissection. The TORS flow was 4 weeks of recovery, followed by 6 to 6.5 weeks of post-op radiation plus or minus chemotherapy pending the hypothetical pathology. And all these patients in our model received post-op radiation because they were N2 disease. So this is a little diagram of our model. So you can see that TORS patients either had post-op radiation or post-op chemotherapy and radiation. It was assumed 100% PEG tube rate for the post-operative chemo and radiation. And then if they're NED, some of them will have the PEG tube removed. For the TORS patients going to post-op radiation therapy, assume that those patients would not need a PEG tube placed. And then the red circles, probably hard to see from the back, you can recur locally and be salvaged, and then you die of other causes. You can recur locally and then there's no salvage, so you can either die of other causes or die of your cancer. And patients who had distant metastatic disease were presumed to die of their cancer in the model. So to do this model, certain assumptions were made, and these are the right. So no evidence of disease to 3 or local regional recurrence. These assumptions were based on published literature, both with TORS and with primary chemo and radiation. With the chemo radiation arm expected to have a local regional recurrence of 11.9%. The TORS plus radiation or radiation chemotherapy of 10.8%. Having residual nodal disease after chemo radiation was 7.6%. 8.7% distant metastatic disease. And then here's the distant metastases to death, local regional recurrence to death, indication for adjuvant chemo and radiation. So these were the baseline values incorporated in the model. These are the toxicity probabilities incorporated in our model. With the baseline feeding tube dependence, if you had TORS followed by radiation alone, low of 3%. In the model, we had 100% if patients received chemoradiation or TORS followed by chemo and radiation. But at 3 months, that dependence has decreased and is much lower at 1 year and 2 years. We assume that the PET scan, here's at the bottom, that the PET scan specificity was 94.3%. So for the cost-effective part of the model, and this is based on published cost-effective parameters, if it was less than or equal to $50,000 per quality of life year, then the treatment was deemed clearly effective. 100,000 probably effective, 200,000 possibly effective. We assumed a high-risk pathology rate of the patients undergoing TORS in our model of being 30% based on published data. The utility analysis was based on previously calculated data that was published last year. We did a sensitivity analysis to vary the feeding tube dependence, the hospitalization, and the local recurrence rates, and costs were determined by Medicare. So our hypothetical patient was actually 65, which is a little bit older than the typical HPV patient, but it allowed us to have the costs from the Medicare for the surgery. And here's the utilities. I won't go through too much, but basically the lowest utility score is someone with distant metastatic disease. Second lowest is local regional recurrence. That also matches the utility score within the first month of surgery, within the first month after TORS. So here are the results. So our model was calibrated to approximate the numbers of RTOG 0129 for disease-free recurrence. And the disease-free predicted recurrence in our model was 86.7% at 2 years, which is not too far away from the P16 positive group and the recent RTOG 0234 group, which for cisplatin was 86.4%, docetaxel 76.2%. So using those baseline assumptions of the model, primary chemo and radiation was $50,000 and a quality adjusted life expectancy of 7.31 quality adjusted life years, and that was cheaper than the primary TORS. And the quality the quality was a 7.29 compared with 7.31. The vast majority of the increased cost in the quality decrement was for having patients that underwent the TORS and would require the chemotherapy and radiation. When this was done as a one-way sensitivity analysis, those utilities figures that I talked about did not play a role. So it was basically determined with the one-way analysis. So chemoradiation is really driving the cost of care for patients having TORS followed by chemo and radiation. So if you set the pathology, we did a two-way analysis setting the pathology, high-risk pathology, meaning they require that post-op chemotherapy, to the radiation at 30%. If the utility following TORS with radiation was better than with chemo and radiation at that set point, then TORS became a little bit more cost effective. Also, if you lowered the local recurrence risk post-TORS, then TORS became clearly or probably cost effective. So basically, if TORS dropped the number of patients needing post-op chemotherapy to 30%, then chemoradiotherapy, regardless, is still cost effective. So you really need to drop that chemoradiation therapy quite far below to make a difference and recommend doing TORS followed by post-op chemoradiation in our model. However, we did find a local regional failure risk where the economic benefits really favored TORS, and TORS became less than $100,000 and less than $50,000 per quality of adjusted life year if the local recurrence rate was 7.7% and 5.5% respectively. And our thought was, well, given that at the 8-year RTOG 0129 trial, the local regional failure rate in the best of the patients was 13.9%. It could be that there's a subset of patients that are relatively resistant to radiation therapy. So in general, our models show that if upfront surgery can improve local regional control by 4%, then it becomes a tool that we should further study with hopefully randomized controlled trials. And one of our hopes is that information from those trials that are ongoing that really provide local recurrence rate can help inform the model to see if we should go forward and really push doing TORS followed by post-op radiation plus or minus chemotherapy as a strategy. That's my last slide.
Mary Jo, thanks for taking me seriously on that cost stuff. That's pretty impressive. Can I just ask? It looked like the pretty similar cost, $50,000-$60,000 in that one analysis. So the one other thing that would figure in here would be patient preference. Do you have anything about patient preference in terms of?
My experience, I think it's a bit variable. You have some patients who say, I just want it cut out. And they have surgeries in their head, it needs to be cut out. And then there are some patients who hate the idea of surgery. The TORS followed by radiation is extending their treatment period by quite a bit because you have the 4-week recovery from the TORS. At the beginning of the talk, the two reasons for using TORS to sort of de-escalate therapy was one, to avoid chemotherapy. Well, that's probably not going to be cost effective. So then the other one is, well, is it going to give you a local regional control benefit? And we just don't know the answer to that.